Hi everybody, welcome to this NEET PG 2025 Anatomy Recall session. Myself Dr. Rajkohila, your Dean of Anatomy faculty. So how was the exams? How are the anatomy questions? Here, can you get to see? The anatomy questions covered high yield topics from almost all the regions in anatomy. There were no questions in thorax in anatomy, more number of questions from head and neck anatomy, right? And yes, definitely one question from histology and embryology. As usually, like more questions were image-based questions and case scenario. Yes. Which of the following is not carried by the structure marked A in the image? So what is this image? This is again a high yield topic. Let us get oriented to this image. Can you see the cervical vertebra here? Right? So this is going to be posterior and this is the trachea. Okay, so this is anterior. And on the lateral aspect, what is marked here is the carotid sheath, where you get to see the common carotid artery, the internal jugular vein, and between the two, the nerve that you see there is the vagus nerve. So structure that is marked here is the vagus nerve, right? Can you identify the same here? This is your vertebra. You can make out the trachea, the esophagus, the carotid sheath with the vagus nerve here. And in our DigiNerve app, we have seen in detail, right, in rapid revision part as well as in PYQ area about functional column, how to remember it in the most interesting way. So the general somatic efferent, yes, it includes the cranial nerves that innervates the muscles of the eyeball and the tongue. 3, 4, 6, and 12. The special visceral efferent column, it includes the cranial nerves that innervates the muscles that are going to be derived from the pharyngeal arches. The nerve of the first arch, the second, the third, right, the fourth, and the sixth arch. General visceral efferent column, no other way you have to memorize. Cranial nerve which carries the parasympathetic fibers. What about general visceral afferent? The cranial nerve that's going to innervate the carotid body and carotid sinus. 9 and 10. Special visceral afferent column includes the cranial nerves that are going to carry the taste sensation from the anterior 2/3 of the tongue, from the posterior 1/3 and the posterior most part, isn't it? General somatic efferent carrying the sensation from the body wall. Yes. Do you remember we made a table? Yeah, that made the things more simplified. So you can see that the cranial nerves 9 and 10, they, yeah, occupy most of the functional column, excluding the first and the last. That makes it easy, right? So the vagus nerve, the 10th cranial nerve, doesn't carry general somatic efferent. General somatic efferent includes 3, 4, 6, and 12, right? This is a standard question, right, of moderate difficulty, a high yield topic. Coming to the second one, during an explorative surgery, an injury caused to the epiploic foramen led to bleeding. Which of the following structures forms the posterior boundary of the foramen? So the epiploic foramen, what do you know about it? It's again a high yield topic. Yes, so this is the liver and the stomach. This ligament that you see here is the lesser omentum. This is the right free margin of the lesser omentum, right? If I put my fingers behind this right free margin of lesser omentum, that is the area of the epiploic foramen, right? Which is the only communication between the greater sac of the peritoneal cavity and the lesser sac of the peritoneal cavity. So if I dissect the right free margin of lesser omentum, what are the structures that I see here in the anterior boundary of epiploic foramen to the, yes, right will be the common bile duct. To the left, the hepatic artery proper. Just behind and between these two structures, this is going to be the portal vein. Now, what is that they've asked? The posterior boundary of epiploic foramen. What is it? Can you see something blue here? And this is the aorta. What lies to the right of the abdominal aorta? The IVC, right? The inferior vena cava. So the epiploic foramen, anterior boundaries formed by the structures that lie in the right free margin of lesser omentum, and the posterior boundary, yes. Again, you can see the stomach here. This is your right free margin of lesser omentum with the three structures. This is our abdominal aorta and the inferior vena cava. Another important point to remember about epiploic foramen is that, yes, it lies opposite the body of 12th thoracic vertebra. So this was again another standard question. Hope you got it right. A patient presents with muscle wasting, reduced tone, and weakness in the left hand. Fine motor movements like the downading are impaired. Which of the following structure is most likely affected? So, muscle wasting, reduced tone, weakness. Yeah, hypotonia, paralysis, flaccid type of paralysis all points towards lower motor neuron type of palsy, right? Where are the lower motor neurons situated? Of course, in the spinal cord, in the brainstem, but in the brainstem, we get to see the cranial nerve nuclei that innervate the muscles of the head and the neck, right? Okay. Now, what lies in the internal capsule and the corticospinal fibers? So the internal capsule, it has the corticospinal, the corticobulbar, right? The corticopontine fibers, the descending fibers coming from different parts of the cortex, right? From or the frontal, parietal, temporal, occipital lobe and descending down. So lesion of the internal capsule will lead to contralateral upper motor neuron type of paralysis, spastic paralysis. The same thing. After decussation of the corticospinal fibers in the medulla, in the lower medulla, after decussating, right, what happens? Ipsilateral type of spastic paralysis. Okay, so please remember hypotonia, muscle wasting, flaccid paralysis, right, refers to lower motor neuron type of palsy. And yes, these lower motor neurons are typically situated in the anterior gray horn of the spinal cord. Right. Coming to the next question. The defect shown in this image. So here you can see a abnormal communication between the pulmonary trunk and the aorta. We call it as the patent ductus arteriosus. And please remember, this is again a high yield topic, previous year question, a repeat question that you should definitely have studied, right? Pharyngeal arch derivatives. Now, let us look into the sixth pharyngeal arch. Right? The sixth pharyngeal arch artery, it is going to give rise to the pulmonary artery, both on the right side and on the left side. On the left side, you can see there's a communication here extending to the aorta. We call it as the ductus arteriosus. Normally, it disappears, right? It disappears later and it forms the ligamentum arteriosum. It obliterates to form the ligamentum arteriosum. If it persists, we are going to call it as the patent ductus arteriosus, right? And that the anatomical basis goes back to the, yeah, anomaly related to left sixth pharyngeal arch artery. Which of the following structures, I'm sorry, which of the following structures do not pass through the market structure A? What is this market structure A? Yes, what you see here in the posterior cranial fossa, this bigger opening that you see here is the foramen magnum. And this one that's pointed out, that is the jugular foramen. Again, this is a high yield topic, a previous year question also. So initially, we'll be learning like name of the foramen, what are the structures passing through. But then later on, they started asking questions. What are the boundaries of the foramen, right? All that. So here again, the jugular foramen, yes, this is the jugular foramen, yeah. And it has three compartments, anterior, posterior and a middle compartment. The anterior compartment and the posterior compartment, yes, is traversed by the veins. In the anterior compartment, it is the inferior petrosal sinus. Posterior compartment, the sigmoid sinus is going to continue as the internal jugular vein. What lies in the intermediate compartment? The three cranial nerves, 9, 10, 11. And right, once they have asked previously, remember the 10th and the 11th cranial nerve, they share a common dural sheath. Okay. One more question related to the same topic. A fracture of the base of the skull involving the jugular foramen and the 9, 10, 11 cranial nerves. What is it called? Anyone? Burnett syndrome. Very good. Okay. So the structure not passing through the jugular foramen, obviously hypoglossal nerve that passes through the hypoglossal canal. Identify the structure where the shown epithelium is located. This is again a repeat question, a very important topic. Yes, I'll zoom it a bit. Right. So here you see a sort of stratified epithelium. Many layers, isn't it? Carefully concentrate on the shape of the nuclei that is located in the topmost layer. Okay. So here you can make out nice round nuclei, which is very characteristic of umbrella or the dome-shaped cells seen in transitional epithelium. What is the other name for this transitional epithelium? Urothelium. Right, that lines the urinary tract starting from the minor calyces, the major calyces, the pelvis of the ureter, the urinary bladder, and yes, a major part of the urethra, isn't it? Okay, now I'll show you a few more pictures. What is this? Here again, look into the epithelium here, many layers. The topmost layer, flat nuclei, non-keratinized stratified squamous epithelium. And you see glands in the submucosa, you see muscle layer. Come on, what is this? Yes, esophagus. Non-keratinized stratified squamous epithelium. Here again, another important, yes, again a previous year question, frequently asked. This is the pseudo-stratified ciliated columnar epithelium with the goblet cells, right? You see the seromucous glands here in the lamina propria. And this here is the hyaline cartilage. What slide is this? Yes, trachea. Okay. And here again, a magnified version. This is the umbrella or the dome-shaped cells in the transitional epithelium. And this is a cross-section of the ureter. You can see the mucosa folded, right? The transitional epithelium. This, yeah, the mucosa is again folded, lined by ciliated simple columnar cells, the fallopian tube, right? So obviously, transitional epithelium, the dome-shaped, umbrella-shaped cells are the topmost layer, points to the ureter. Okay. Coming to the next question. What is the nerve supply of the marked structure A? So in this image-based question, you see the mandible, right? The bony landmarks. This is the mandible. You see the hyoid, and this is the mastoid process. So what you see here, this muscle, yeah, anterior belly of the digastric, originating from the digastric fossa right on either side of the midline. And this is the posterior belly of the digastric, inserting into the mastoid process. Can you tell me, what is this muscle? This is the stylohyoid, right? And this one here is the mylohyoid. The stylohyoid, it lies above the posterior belly of digastric. I usually call it as the SPB muscle. Stylohyoid above and the posterior belly of digastric below. Both the stylohyoid and the posterior belly of digastric is supplied by Yes, the nerve of the second pharyngeal arch, facial nerve. Okay, facial nerve. And what about this one? Anterior belly of digastric and the mylohyoid. They are innervated by the nerve of the first pharyngeal arch, the mandibular nerve, right? But we don't get to see any option mandibular nerve. So this mandibular nerve, it gives off the inferior alveolar nerve, and this inferior alveolar nerve will give rise to the nerve to mylohyoid before it traverses the mandibular foramen in the mandible. And the nerve to mylohyoid, it innervates, yes, the mylohyoid muscle and the anterior belly of digastric, right? So in a cadaveric image also you should be able to identify the same. Can you make out the anterior belly here? This again is the posterior belly, and above that, this is the stylohyoid. Okay, so that's the answer. Moving on to the next question. Again, this is a very high yield topic which they've been asking over the recent years. Nerves at risk during submandibular gland surgery. During resection of submandibular gland, there's accidental injury to a structure running superior to the posterior belly of the digastric muscle. Which of the following structure is likely to be injured? Yes. So during submandibular gland surgery, especially closer to the submandibular duct, the nerve that is closely related is the lingual nerve, presenting a triple relation to the duct, above and then below and then winds up medially, right? So this we call as the triple relation of the lingual nerve to the submandibular duct, right? Okay. And then you can see the 12th nerve here. Okay, I'll show you a few more images. So here what you see, this is the posterior belly of the digastric muscle. The clue that they have given here in this case scenario is a structure running superior to the posterior belly of the digastric, right? So this is your internal jugular vein. You can see the internal carotid artery, and between the two, yes, the 11th nerve, 10th nerve and the 12th nerve. Okay, I'll show you one more picture. The arteries that are related to the posterior belly of digastric. So what you see here, this is the posterior belly of the digastric, isn't it? Right. Lower border of the posterior belly of the digastric is related to the occipital artery. The upper border that you see here is related to the posterior auricular artery in the posterior part. And can you appreciate the tortuous course of the facial artery also? Right. I'll show you one more image. Be with me. Okay. Here I'll zoom it a bit. This is the anterior belly. Yes. This is the posterior belly. You can see the submandibular salivary gland here, right? Immediately above the posterior belly. This nerve that you see here is the hypoglossal nerve, right? Yes. So for this case scenario, going with the clue, the right option is hypoglossal nerve. A 20-year-old boy got severe pain due to hyperextension of the shoulder while training in the gym. The trainer expected a probable disruption of the structure marked A in the image below. Which site is affected? So what is this A? You see the scapula. This is the humerus. The glenoid fossa. The lower part of the glenoid fossa having its origin is the long head of triceps brachii. Okay. So here you can make it out right. This is the glenoid fossa. From the infraglenoid tubercle, we get the long head of triceps brachii. Okay. And compared to it, from the supraglenoid tubercle, we get the, yes, long head of, this is your glenoid, okay. From the supraglenoid tubercle, we get the origin of long head of biceps brachii. So here, an image showing the dorsal surface of scapula. The glenoid fossa is here. And supraglenoid tubercle, long head of biceps. Infraglenoid tubercle, yes, the long head of triceps brachii. Yeah, so this is the right answer. And the 10th one is a very easy question. Definitely all of you must have got it right. What are the contents of umbilical cord? Okay, so all of you must have seen the umbilical cord. Remember the histological image of it? You get to see two thick-walled structures. The two thick-walled structures are the arteries, right? And this thin-walled structure is vein. So you have the right umbilical artery, left umbilical artery. Right umbilical vein, left umbilical vein. But only one umbilical vein is here, right? The left umbilical vein is left behind. Okay, so that makes it easy. Two arteries and one vein. 11th question. A known case of anal carcinoma with mass near the anal opening comes for a follow-up. Which of the following lymph nodes are most likely involved? Again, all of you know that this is a very high-yield topic. So what is this landmark that you see here in the interior of the anal canal? The pectinate line. And definitely you must have read that the development, the arterial supply, the venous drainage, the nerve supply, the lymphatic drainage above and below the pectinate line varies, right? So any lesion below the pectinate line, especially closer to the anal canal, we can expect enlargement of the superficial inguinal lymph nodes. Okay? Superficial inguinal lymph nodes. What is the root value responsible for Meralgia paresthetica? I am sure if you've gone through the previous year questions, seeing this very question, you must have felt very happy, right? It would have consumed less time to answer it because every year they keep asking it. It's a very high yield topic, okay? So, yes, what is Meralgia paresthetica? Pain along the lateral aspect of the thigh. And this area is innervated by which nerve? The lateral cutaneous nerve of thigh. The lateral cutaneous nerve of thigh or the lateral femoral cutaneous nerve, it is a branch coming from the lumbar plexus. Right. And we also know that this is the nerve which is frequently injured in laparoscopic inguinal hernia repair with the root value L2, L3. Okay, so as you see here, this is the inguinal ligament. The lateral cutaneous nerve of thigh, usually it traverses below the inguinal ligament. Sometimes it can get trapped between its fibers and that will lead to pain along the lateral aspect of the thigh, which we call it as the Meralgia paresthetica. So the root value is L2, L3, and that is the right answer. Coming to the last question for our recall, a girl presented with foot injury and gave history of forceful eversion of foot. Which of the following structures affected the most? Right? So this is the medial and this is lateral aspect, right? So inversion injury or eversion injury can quite happen. Inversion injuries are quite common. Okay. When there is a inversion injury, when the foot is turned inward, the structures on the lateral aspect is stretched. And for eversion injury, the structures supporting the medial aspect will be stretched and injured. Okay. So inversion injury mainly affects the ligaments on the lateral aspect. Eversion injury, yeah, it affects the main ligament on the medial aspect, which is more stronger, the deltoid ligament. And that is the answer. Okay, all the other three ligaments are related to the lateral aspect of the foot. So this will be the best choice to go with. So coming to the wind up of the NEET PG 2025 anatomy recall. Yes, most of them were standard questions from high yield topic. Okay, moderate difficulty. Hope you got it right. So done and dusted. Now it's time for you to take a chill. Thank you.